Thank you all for coming. Good evening, and welcome to Making Michigan, which is the Bentley Library's series on the history of the University of Michigan. I'm Gary Krenz, the director of the Judy and Stanley Frankel Detroit Observatory, which, as you all here know, obviously is not in Detroit. This is something we struggle with all the time. I'm pleased to welcome you to the observatory, and I'm pleased to welcome our online audience on YouTube. Tonight we have a very exciting and timely presentation. I'm thrilled to have Tim Johnson join us to talk about the remarkable history of the U of M-Ghana partnership, which he captures in his new book, really brand new, as in today, I understand, More Than First Do No Harm, Academic Global Health. Tim was kind enough to share with me a pre-publication copy of his book, and I found it enthralling. I'm, of course, not a healthcare professional or public health professional, and undoubtedly those of you who are would get even more out of it than I did. But I do have to say that as someone who has spent a career at U of M doing my best to nurture deep university values and cosmopolitan participation, this is a book full of insights, ideas, and episodes from which anyone committed to higher education and global engagement can learn a lot. It is not just a book about a particular program or set of programs. It's also about education, the place of the university in the world, and about equity, justice, and respect in collaborations. You know, we are witness at this particular time to a tremendous amount of pain and suffering in the world. And we clearly see the temptation in many cases and the actual effort in other cases to withdraw, to resist the pulls of compassion and cooperation, or worse, to lash out in frustration, fear, or toxic chauvinism. Tim's book is an antidote, I think, a story of the difference one person can make and how so much of that difference comes down to collaboration, to working with, indeed promoting and nurturing the work of others. I really highly recommend it. Timothy Johnson is Arthur F. Thurnau Professor of Obstetrics and Gynecology and Women's and Gender Studies at the University of Michigan, where he was Bates Professor of the Diseases of Women and Children and Chair of the Department of Obstetrics and Gynecology for 24 years. He is a high-risk obstetrician, and his research interests are fetal behavior, prenatal care, medical education, and capacity building for health, global women's health, global health ethics, and assessment and prevention of sexual harassment in academic medicine. He is, of course, active in international teaching and training, especially in Ghana. He has received U of M's President's Award for Distinguished Service in International Education, the Distinguished Service Award of the American College of Obstetricians and Gynecologists, and many other honors. He has authored over 300 articles, chapters, and books, and is an elected member of the National Academy of Medicine. And I know him to be all around a person of tremendous decency and generous spirit. So please join me in welcoming Tim Johnson.
Thank you very much. It's a great pleasure to be here tonight, and it was a great honor when Gary, who's been my friend for several decades, invited me to come and speak at this wonderful new building as part of the Making Michigan series. As many of you, there's so many of you that are my friends in the room, and so many of you who went to the University of Michigan around the time that I did and spent hours and hours in the graduate library studying and what we used to study called books and worked in carols and really had tremendous times together. And so it's a pleasure for me to be here tonight and to talk about this book that actually became available online today on the University of Michigan Press. And it's a book that I've been working on for a number of years, and I'm happy to talk about tonight. I'm happy to plug it shamelessly. The title, we'll talk maybe a little bit about why it came to be called More Than First Do No Harm. But in addition to writing a memoir, in addition to writing kind of a guidebook around how to do global health, I also wanted to make sure that it was clear that doing global health had ethical and moral imperatives that were important not only for individuals but for institutions. And so that's why I talked about it. The cover, if for those of you who don't spend time in Ghana, is kente cloth. Normal kente cloth is red and green and blue, and this is actually a piece of blue. Anybody who goes to Michigan immediately gravitates towards anything that's blue, right? If there's a blue tie, you buy the blue tie. If it's a blue shirt, you buy the blue shirt. And if there's a solid blue kente cloth, you buy that. This is actually what I'm currently using as my bedspread, which I thought made a good back book cover. And we'll talk a little bit about the Michigan sign on there. But this is really a story about my journey and my time that occurred in Ghana. So this is a story about a place, but it's also a story about a time. In 1985, Alan Rosenfield, who was one of my mentors and was the dean of the School of Public Health at Columbia, and also an OBGYN, a very distinguished family planning reproductive health practitioner, wrote a paper that basically shook the world. It was entitled Maternal Mortality, a Neglected Tragedy, Where is the M in MCH? And what he talked about was the fact that the burden of maternal mortality was extremely high in 1985, and in fact had been stable and high for a number of years. And this was despite the fact that the burden from childhood mortality has been dropping. And that's because of childhood immunizations and oral rehydration therapy for diarrheas, which were a major cause of infant mortality. So the 1970s and the 1980s had seen a marked drop in infant mortality, but no drop in maternal mortality. And this was really a clarion call that ignited a national and international efforts around what was called safe motherhood. Come on in. And the Safe Motherhood Initiative was a WHO initiative that focused on maternal mortality. So it was in the context of this maternal mortality initiative and the Safe Motherhood Initiative that I first traveled to Africa. And I traveled to Ghana because at the time, in 1986, the Iron Curtain had fallen and USAID was and Ghana was interested in getting funding from the West, and USAID was interested in funding sub-Saharan Africa. So there was an opportunity as Ghana, which had been getting all of its support for the previous 15 years from the Russians and the Cubans, realized that money was going to be going away, and so they decided that they needed to look to the West. And so I was asked to go and give some talks in Ghana, and that's how this whole thing happened. In fact, one of my colleagues from down the hall was supposed to give the talk, and he came by and said, I'm supposed to give this talk in Ghana in a couple of months. Do you want to go give it instead? And he was supposed to talk about laparoscopy and advanced surgical techniques, and I said, well, I'll go, but I'm going to have to talk about maternal mortality and childbirth and those kinds of things. And he said, nobody cares what you talk about, just go. And the reason nobody cared was that there was supposed to be a big party. The OBGYN Society of Ghana had not met in about 25 years, and so USAID was supporting a party for all the OBGYNs in Ghana, and I was taking the money. And so that's how I happened to go to Ghana, and it transformed my life. This was actually a picture that was taken on the labor and delivery unit at the maternity block at Women's Hospital. One of the largest hospitals in Ghana for all was the maternity block because they had such a high maternal mortality. They had very large maternity hospitals. This hospital did almost 20,000 deliveries in the 1980s. And women came and they delivered their babies, and then they often stayed in the hospital. There weren't enough beds, and so women occupied the beds and the floors, and all the extra space was occupied by women who were either planning to have their baby or had had their baby. And the striking thing, this is 1986, striking thing, first of all, is the colors, right? It's not all white and drab, it's bright, and that's one of the things that strikes you when you go to Ghana, is you suddenly see bright colors in addition to kind of the amazing tropical smells. And secondly, how friendly people are. And I love this picture of this little postpartum woman lying on the floor giving a little hello. And this is the picture that I've shown forever. The woman in the bed has the bed because she has a new baby and she's changing diapers probably in that bed. Now, at the time in the 1980s, women died disproportionately because of common problems in low and middle income countries. They died because of ectopic pregnancy, which was some disease that we treated aggressively in the United States. They died of complications of abortions, spontaneous abortions, miscarriages, or induced abortions. So even though abortions were legal in Ghana in the 1980s, people didn't know about it, and so they went to traditional healers and were given sticks and bleach and things to use. But also women who had miscarriages didn't have any place to go. They would start bleeding, they would continue to bleed. And in the United States, when that happens, we do a D&C and we remove the excess tissue and the bleeding stops. There was no way for people to remove the excess tissue. And so women either bled to death or they got a superimposed infection. So the common causes of maternal mortality were infection, hemorrhage, and a disease called preeclampsia, where women developed hypertension and hypertensive disease and had seizures and died as a result of that. So this is a common theme. And in fact, in the United States now, we're seeing the same problem. The common causes of maternal death are bleeding, infection, and hypertensive disease. It's just a difference of scope. So in the United States, the maternal mortality may be 25 per 100,000. In Ghana, it's down to 300 per 100,000. So a much higher burden. And in many low-income countries, women say, you hear people say things like pregnancy is a long journey and many people don't come back, which would be unheard of us to think in the United States. And in Sierra Leone, currently, the maternal mortality is the highest in the world. Your risk of dying in childbirth in Sierra Leone is about 1 in 8. So if you can imagine 1 in 8 people dying in childbirth in 2023. And postpartum hemorrhage, so women would deliver and then continue to bleed after delivery. So maternal mortality is defined as the death of a woman while pregnant and up to 1 year after pregnancy from any cause. And so we use 100,000, we use per 100,000 live births just because we can count the number of live births. We can't count the number of pregnancies, right? We don't know how many people are pregnant, so we can't use that as the denominator, which would be our preferred denominator. But we know how many babies are born, we count that, so we can count the number of maternal deaths per 100,000 live births. And in the United States, it's a problem because the maternal mortality rates, as most of you have been reading, has been actually going up in the last 5 to 10 years. And that there's a marked racial disproportionality where black women are about 4 to 5 times more likely to die in childbirth in the United States than white women. And Hispanic women are less likely to die in childbirth than white women. So we have a marked racial disparity with African American women dying disproportionately and Hispanic women having what's called the Hispanic paradox, where they're less likely to die in childbirth, none of which we understand completely. But what we do know is that hemorrhage, infection, and hypertension are the major causes of these problems. Another one of the people that I admire greatly was an Egyptian professor named Mahmoud Fatala, who said pregnancy-related deaths are often the ultimate tragic outcome of the cumulative denial of women's human rights. Women are not dying because of untreatable disease, they are dying because societies have yet to make the decision that their lives are worth saving. Simply put, they die because they do not count. And I think that's something that's always struck me, is that kind of the lack of the role of women in society. And in many parts of Africa, it's easy for husbands to get another wife, and so maternal mortality simply doesn't count. Women are replaceable. And in the United States, we need to start paying attention to what's going on in terms of our racial disparities as well. And so we have to count, we have to report on maternal mortality, we have to talk about what's going on. Well, in 1986, I went to Ghana, I gave my talk, and I met with the doctors and the medical students and the interns on the service. They didn't have any OBGYN residents at the time. They didn't have programs to train OBGYNs. They had medical students, they had their own medical schools, they had medical students, and they had internships basically where people just rotated on the different services serving as doctors. But in 1986, if you wanted to train an OBGYN, you had to leave the country. And I was actually very involved in the United States in residency training. I was the residency program director at Johns Hopkins for almost 15 years. I had spent my career training people to become OBGYNs. I'd spent my career training medical students, hoping many of them would go into OBGYN. And I actually had trained people to be subspecialists in maternal fetal medicine, which is my specialty. And so I said, why don't we have a residency program here in Ghana? And the people there said, we'd love to have a residency program, but how would we start it? How would we run it? How would we make it work? We've never done anything like that. Can you help us do that? And I thought, well, maybe I can. So part of my story in the book is these kind of opportunities that come. So, here I was in Africa thinking that maybe they should start a residency training program. And I came back to the United States, I made a couple phone calls, and I called a colleague who was at the American College of OBGYN, and I said, does the ACOG ever support residency training? And they said, well, no, but just last week we had this guy that was visiting from the Carnegie Corporation of New York who was interested in capacity building, interested in safe motherhood, interested in these maternal mortality issues, and he might be interested. So I called Adetokunbo Lucas, who was a Nigerian who was president of the Carnegie Corporation of New York, and he said, I've been waiting for this phone call. And we wrote a grant, and about 3 weeks later, we had $7 million to set up a residency training program in Ghana, with a proviso that it had to be done in conjunction with the American College of OBGYN and the Royal College of OBGYN, because he wanted the professional societies involved. And so we had a series of meetings between Ghanaians and the people from the Royal College and people from the ACOG, and I was one of the representatives from the American College. I was the junior representative, and we had more senior people that were involved, and I learned a lot from that. But we had a series of meetings and decided that, yes, we could potentially do this. And the Ghanaians were willing to take on the major brunt of the work in the organization, and so we set up a Ghana management committee, and the Ghanaians were the managers of the program, and the people from the US and the UK were the advisors. So we had a Ghana management committee, and we had an external advisory committee. I think it was very important that we did from the very beginning, had local autonomy in terms of the way the program developed. So kind of fast forward to the program. It was established in 1989. The first residents were taken in 1989. And the Ghana Management Committee picked what they liked from the UK way of teaching, what they liked from the US way of teaching, what they liked from the ways that they had been taught when they had been taught locally in terms of their basic training, and came up with a 5-year curriculum to train doctors in Ghana to be obstetrician gynecologists. And the goal at the time was to certify by the West African College of Surgeons, which was the professional society that was based in Nigeria, but that included Ghana, Cameroon, Sierra Leone, Liberia, a couple of other countries. It was both it was the accrediting body, so it said we will accredit the training program. We will certify that these are adequate. We will certify the graduates, and then they will join us as a professional society. So in the United States, as those of you who are in medicine know, that we have separate groups that charge a lot of money to be accrediting bodies. They charge a lot of money to be certifying bodies. They charge a lot of money to be professional societies, and so you have to pay 3 times to be able to get through the system. In Ghana, they had a single organization that did the accrediting, the certifying, and was the professional society. And for a long time, it was the West African College of Surgeons until the Ghanaians set up their own group that was called the Ghana College of Physicians and Surgeons. And so Ghana now certifies, accredits, and has their own professional society. And so this residency program then took off. We started with a lot of people from the US and the UK shuttling in to give lectures and to give talks and to prepare people for the examinations. And I guess, the question I was always asked was, why did you do OBGYN? Why didn't you pick general surgery? Or why didn't you pick primary care? Because obviously people needed primary care, and they needed basic community health and public health. Why did you pick a specialty like OBGYN? And I mean, the easy answer is because I'm an OBGYN. But more importantly, it was because at the time there was a major international focus on safe motherhood. And the thinking was that if we trained OBGYNs that we might be able to have an impact. Because often in Ghana, people who needed a cesarean section would have to wait 3 or 4 days for a physician to become available. That's how bad things were. And to make a long story short, the program that started in 1989, by the summer of 2018, 245 specialists had trained in the program, had completed the program in Ghana, had been certified as board-certified OBGYNs by the Ghana College of Physicians or by the West African College of Surgeons. And of those 245 who had trained, 235 were still practicing in the country. 3 of the people who had trained had come from the Gambia to train and gone back to the Gambia. So we kind of get partial credit for the fact that they were still practicing in West Africa, if not full credit. 6 people had actually died, and that speaks to the very high mortality of people who were in their 40s and 50s in Ghana. People were still dying at a disproportionate rate from cardiac heart disease and hypertensive disease. And only 1 person had left and come to the global north, come to the United States. And this was a guy who was married to an American, and so he had 3 American children, and it was fairly easy for him to get a green card and then an American passport. Although interestingly enough, he never could practice OB/GYN in the United States. He never qualified. He actually is practicing as a family physician in South Carolina. So very successful program, not only in terms of the numbers that trained, but in the retention. And it's important to know that prior to this, one of the big issues that people always talked about was brain drain. That people were being trained to be doctors in low and middle income countries, and they were leaving. And people always said, well, you're going to train OB/GYNs and they're going to leave and go other places. And in fact, this program has been a poster child for retention and for in fact, leading to reverse brain drain, because as this program got successful, Ghanaian doctors who were in the United States said, hey, I'd like to go back and finish my career in Ghana, and started moving back. Part of the program from the very beginning was the importance of research and engagement in clinical research. And so by 2018, there were over 140 publications that had been written by faculty in Ghana who'd gone through the system. And what happened was, as you finished your residency, and many of the early people got jobs at the University of Ghana or at the Kwame Nkrumah University in Kumasi, and they stayed there and they got promoted, and some of these people went on to become heads of department, would become deans. One of them went on to start his own medical school. Another person went on to become a member of parliament. Another person is now currently a member, is actually the rector, the head of the Ghana College of Physicians and Surgeons. So in terms of career development, there was really, really opportunities for people to move up, not only in the academy, but in the private sector and in other places as well. 3 textbooks were published, and this was really an important piece. We have a medical student who's visiting here. We'll talk a minute about these exchanges that started going back and forth, but we have a couple of medical students here that are here this month from Ghana. And I pulled some of the textbooks from the wall, because there were 3 textbooks that were published. One, a comprehensive OB textbook, one on comprehensive gynecology, and one on reproductive health. And those are paperback books that were published in Ghana and available for a very reasonable cost. Buying a Western textbook would cost a couple $100. And these were paperback books that were available for $25 or $30. So not only that, but those were the textbooks that people based their exams on. And so the students read these books because they knew if they read these books, they could get a good score on the exams. And OB/GYN was one of the favorite areas, because in other departments, they didn't have like the textbook that you could read and get a score on your exam. So number one, people liked OB because they could, pass the course fairly easily. Secondly, there were residents that were exciting, and so the pipeline got to be very, very strong. People went on to become chairs of the department, and they now have fellowships in family planning and GYN oncology and GYN and urogynecology and maternal fetal medicine. And we've had those people come and visit us too. So we have had from the very beginning a resident exchange program, then a medical student exchange program, and now a fellow exchange program. And those have all been very successful in OB/GYN with a kind of bi-directional exchange of learners. And all along the way, we wrote regular papers on how did we develop the program, how did we evaluate the program, why did people stay in Ghana. We wrote a landmark paper on why do people stay, and they stayed because there was a high-quality program that allowed them to be well-trained and economic opportunity in the country. And we've written a lot about the bidirectional exchanges and what, of the medical students from Michigan who go to Ghana, what is their experience like? How is it transformational for them? And it's been an important part of the Global Reach program, which is our medical school training program, and we've got data on why students like to do global experiences and how it changes them. And also data on, what is it that the Ghanaian students like. Interestingly enough, it's not all about technology for the Ghanaian students. one of the things that they learn and that they appreciate is the relationship that doctors have with their patients here. The system in Ghana tends to be a little bit patriarchal, where the doctors walk in and say, I'm the doctor, you're going to do this. Kind of the old British system that they haven't totally gotten away from. The students who come here are like, oh my God, we can't believe the way you practice patient-centered care and that you have shared decision-making and the patients are involved with this. And so there's been a transformation of the students going back, talking about the way Michigan and the United States does healthcare that's made a big difference in terms of practice. And this is just a quick graph that'll show you how they're you know, it's a geometric increase. In the first couple of years, you're like, oh, are we ever going to train anybody? And then all of a sudden, it takes off, and the trainers train the trainees, and everybody starts getting the program fairly large, to the point that you know, 245 OBGYNs in Ghana is remarkable. We've also, with GPS, tracked where people practice. And this is a slide that shows on the left in 2010 where the graduates were practicing. And you can see by 2017, they were already starting to disperse around the country. So you can see that there's an impact in terms of people spreading out from the teaching hospitals to the regional hospitals and then to the district hospitals. And this is what you need with the critical mass. We also published a paper on the public health downstream benefits of training OBGYNs. One of the critiques of the program is, why are you training specialists? And we were able to show that the OBGYNs trained medical students, that they trained nurses, that they trained nurse midwives, that the nurse midwives trained community health workers, that the doctors trained community health workers, that the community health workers and nurse midwives and doctors started to work together in different ways than they had before. Family medicine started, we'll talk a little bit about that. So there was the downstream public health benefits of training OBGYNs was shown to be real, and also the fact that many of the people who trained in this program and in the other programs I'm going to talk about became leaders. They became ministers of health, they became members of parliament, they became deans, they became kind of policymakers. And this certainly made a difference in terms of the overall practice in the country. This is a picture of the cover of Comprehensive Obstetrics in the text, and you'll see the authors are all African. These textbooks were written by an all-African publication team. So when we asked people, you know, how did this work? Why did it work? One of the papers was, why did they stay? And they stayed because there was in-country training, because the country was economically stable and they felt they had a future, and because they felt strong national and social ties to their people and to their families. Now, it can be argued that we were lucky, because Ghana since 1986 has been relatively stable, both economically and politically. I mean, right now they're having a pretty significant depression and a high inflationary spiral. But you know, people are able to buy food, they're not starving, and the economy will get better. Politics, I mean, since 1986, there have been peaceful transfer of power between political parties consistently, to the point that other African countries were embarrassed, and the Nigerians even had peaceful transfer of power because their next door neighbors, the Ghanaians, had been doing it. So Ghana has been a model for political stability and economic stability, and I think that's important. But you know, other countries are starting to see the benefits of these kinds of programs. Why it worked, people talked about the long-term partnership. And for me, when I went to Ghana, I had a busy life. I was a busy academic, I was doing research, I had 3 young kids. When I decided that I was interested in working in Ghana, I had to find space in my life to do global work. And I decided I was interested in doing global work, but I only had space in my life for one place. And so Ghana has been the place that I've gone back to on a regular basis and have had a regular relationship with and have regular friends in. And you see my Michigana pin. And for me, that's an important lesson. People always come to me and say, you know, I'm really interested in doing global health. How do I get started? And I say, you know, pick a country and start there and develop a relationship, and rather than kind of going all over the place and every year going someplace different. I think there are opportunities for people to have global experiences and not travel internationally. I think there are opportunities for people in the state of Michigan to have a really significant global experience by going to Detroit or going to Muskegon or even going to Alpena, right? People who grew up for somebody who grew up in inner city Detroit, Alpena is a global experience. For somebody who grew up in Marquette, Muskegon is a global experience. And so you don't have to spend a lot of money and do international travel in order to have a remarkable experience. And I think that's another important message. Long-term partnerships, local management and control, extremely important. We always respected the Ghanaians and they made the final decisions. These bilateral exchanges are extremely important. The medical students from Michigan often meet the Ghanaians students who are here, and then when they go over there, they're able to go each other's houses and eat food. Financial transparency was really important from the very beginning. The Ghanaians always saw the grants and saw where the money was coming from. The capacity building, long-term sustainability, and personal relationships and commitment. So let me talk a little bit about this. This picture is actually on the back cover of my book. The top is a Michigana pin. And let me tell you the story behind the Michigana pin, because branding is important and developing an institutional recognition of what you're doing is also important. So Mary Sue Coleman decided, I think in around 2008, that she wanted to globalize Michigan and start doing international travel, and actually said, you know, I'm interested in doing some global travel, where should I go? And the university started looking at where it had a fairly deep and broad engagement, and they came back and they said, well, we think it would be a really good idea for you to go to Africa, and Ghana might be a place to do it. And so she said, okay, I'm going to go to Ghana. And she also, on the same trip, went to South Africa, because Michigan had a large footprint there, and she also went to the Emirates to give a talk. But Michigan is where Mary Sue Coleman first put her foot on an international soil as part of this global initiative. And remember, the first trip that Barack Obama took when he did an international trip was also to Ghana. And most of you have seen that picture of Barack and Michelle Obama, now I'm going to get emotional, walking out of the Elmina Castle, crying from that experience, which still is one of the most amazing experiences of my life. Anyway, I got a phone call from Mary Sue Coleman's office, and they were like, well, Mary Sue would like to take some swag with her. You think she should take some pins, or you think she should take some pens, or do you think she should take some booklets or some paper? What should she take? And at the time, the University of Michigan Alumni Society was handing out black M's with American flags. American flags were very popular. And so the Alumni Society had decided to brand themselves with black M's and American flags. And I said, why don't we do a black M and a Ghana flag for Mary Sue to take over? Nobody will have seen anything like that. And they thought it was a good idea. And these things cost like 22 cents when you buy them in bulk. You would have thought that Mary Sue Coleman was handing out gold bullion. Everybody wanted a Michigana pin. And when they saw them, they were like, where do I get one of those? And she was handing them out to like the Minister of Education, to like the Vice President of Ghana. When she left, everybody had a Michigana pin on. And I think branding is really important when you do this kind of work. Whenever a student comes from Ghana, we give them a Michigana pin, and they walk around with their Michigana pins. And when they leave with a Black M T-shirt and a maize T-shirt that says Michigan on the front. When you go, if those of you who go to Ghana, look, and you'll see people walking all over the place with Michigan shirts on. These became so popular that as Michigan developed other platforms, they developed these same pins. So you'll see Michigan Ethiopia pins, Michigan China pins, Michigan Brazil pins. And whenever Michigan has a major relationship with a new university, they develop these pins. So, good ideas have legs. This is actually Mary Sue Coleman being greeted at the Kumasi airport where she arrived. And this is a person who has got an MPH from Michigan that had heard she was coming and came with this amazing sign saying, welcome to Kumasi. And that's why I'm so glad to talk to this group tonight, because it's so corny, right? But those of us who have lived in this environment and kind of breathe the maize and blue and wear these maize and blue pins and get goosebumps when Mary Sue Coleman arrives at the airport and has a big welcome to Kumasi sign. That makes a difference. So let me just talk a little bit about the spinoff, because this program led to other programs and metastasized. One of the first things that happened is that the Department of Emergency Medicine here at the University of Michigan decided to set up an emergency medicine, the first emergency medicine residency training program in sub-Saharan Africa. And the program was extraordinarily successful. Rockefeller Otang, and Bill Barsan, the chairman, were involved. This is the first group of graduates who went on to become the first trained emergency medicine physicians in Ghana. And not only did they set up emergency medicine residency training programs, but they actually set up a network of ambulances. Before there was emergency medicine, the ambulances just drove around the country doing crazy stuff. And if there was an accident, they would just pick up whoever looked sick on the street and take them. What they developed through the emergency medicine department was phones so that the people in the ambulances could call and say, you know, who should we pick up? There was a bus accident. We've got 60 people here and we've only got room for 4 of them. And the doctors would help them triage and get, you know, if the people who were near death, they didn't take. The people who had a broken toe, they didn't take. They took the people who needed to get to the hospital within that golden hour to get resuscitated by the emergency medicine people. So again, that's an example of the kind of the public health downstream of these kind of training programs. Another program, this is my friend Tom Schwenk is in the audience, and Tom was involved with introducing family medicine in Ghana. This is actually a sign for a family medicine seminar, the first family medicine seminar, because family medicine basically started out of whole cloth. And the Ghana College of Physicians and Surgeons and the University of Michigan sponsored this first family seminar on family medicine at the Ghana College of Physicians and Surgeons, which is a magnificent building. So in OBGYN, in addition to OBGYN, family planning, gyn-oncology, urogynecology, MFM have developed emergency medicine. The emergency medicine department has started a critical care emergency fellowship, so they're training emergency medicine residents and now critical care trained emergency medicine residents. Family medicine has started training programs. The ENT department has started a cranial base and an otology program. Ophthalmology has started a pediatric ophthalmology training program. Cardiology started sending pacemakers. In the United States, if used pacemakers can't be reused. But in other parts of the world, sterilized pacemakers that have been adequately treated can be reused. And so Kim Eagle in the group here started taking partially used pacemakers that still had several years of lifespan in them from people who died, sterilized the pacemakers, made them available to people in Ghana, and suddenly they have pacemaker capacity that's really remarkable, and it basically saves lives. These are people who have slow heart rates, and as soon as you get their heart rate back to 70, all of a sudden they perk up. Life-saving technology, and basically free. One of our colleagues has started a geriatrics and palliative care program. Psychiatry has started training programs there. Gifty Kwachi, who is a general surgeon at the U, has now started a colorectal surgery training program. And Global Reach has started programs in epidemiology and maternal child health research. So not only has this been a clinical program, but it's been programs that work through the School of Public Health. One of the people that we know has started a medical school. Yao Kwakumi, who started as a resident in our program, was the first person in Accra to graduate, went on to join the faculty, then became an assistant professor, then became an associate professor, then became a full professor, then became head of the department, then became dean of the medical school. Then when he had mandatory retirement at the age of 60, started his own hospital, and then started his own nursing school, and then started his own School of Allied Health Sciences, and 7 years ago started his own medical school. He's now president of the Family Health Medical School, which was the first private medical school in Ghana that's now graduating 50 people a year. And it's an amazing place. He was given land on the Atlantic coast to start this medical school. And actually, this is the athletic court at the Family Health Medical School. This is, in the background, is the Atlantic Ocean. I mean, you could have a Hilton hotel on this spot. It's so gorgeous. But this is a picture of the back of the basketball court. The Ghana Medical Student Association said, we'd like to set up a basketball court at this new medical school, but do you think you could find somebody to help us pay half of it? And so the University of Michigan paid half of the basketball court, and so you'll see the symbols up there of the Ghana Medical Student Association and of Block M. So again, this is the Charter for Collaboration. This was an agreement, a paper that focused on an episode that we had where we talked about how should universities relate in an ethical and moral way. And this was actually work that was supported by the Gates Foundation. They gave us a grant to work on collaboration. And they said, the first thing we want you to do is come up with a document that could be reproducible, that people will use to have ethical, moral relationships. And this is the charter. It talks about the importance of human resources for health, and then talks about these primary values that I think are very much Michigan values. One of my favorite quotes about Michigan is the quote that's often ascribed to a former president who said, "An uncommon education for the common man." And I think these values of trust, mutual respect, communication, accountability, transparency, leadership, and sustainability are very consistent with the kind of values that those of us who spend our lives at the University of Michigan see as values here at the University of Michigan. It's important to recognize cultural differences. If you know one country in Africa, you know one country in Africa. They all are individual places with their own histories. Histories in current context matter. Regional and tribal differences exist. Ministries of health and education are necessary partners. In the United States, universities can do whatever they want. But in Ghana, you have to engage the Ministry of Health and the Ministry of Education if you want to get something done. And universities are rarely autonomous. And in Ghana, the Ministry of Health has really been an important partner for us over the years. So it didn't just exist in Michigan. Here is a Michigan-Ethiopia flag from a cover of Michigan magazine, Michigan Medicine's magazine, that talks about Michigan and Ethiopia. Dr. Sanait Faseha, who is an OBGYN, got a $3 million grant from the CDC and an anonymous foundation in the mid 2010s to set up residency training program in Ethiopia. The Minister of Health of Ethiopia, Dr. Tedros, had decided that there were not enough doctors in Ethiopia, and he got quadrupled the number of medical schools. Just said we're going to have 4 times as many medical schools. And a couple of years later, after everybody had graduated from medical school and everybody had done their 2 years of mandatory national service, he discovered there weren't enough residency training programs. And he had a PhD in epidemiology from Harvard, and so he decided, I'll go in the literature and figure out who in the world knows how to do residency training in sub-Saharan Africa. And ka-ching, the Michigan articles came up, and he flew to Michigan and said, I want the University of Michigan to help us set up residency training programs in Ethiopia. And I said, I'm sorry, I only do Ghana, but I have my colleague here, Sanait Faseha, who is very interested in doing that. And she was able, in 4 years, to do many of the things that we'd done in 8 years, because based on our experience, what we knew that worked, what we knew didn't work. She was able to set up residency training programs in OBGYN, and then peds, and then surgery, and then medicine, and fellowships at St. Paul Millennial Medical Center. So the Ghana project is reproducible. That's the other question. Is it sustainable? And how did it sustain it? I told you that the first grant came from the Carnegie Corporation of New York. When the Ministry of Health of Ghana discovered that the doctors were actually staying in the country, they said, oh, we'll fund this program. We've been spending money to send people out of the country and they never come back. If you've got a program that'll keep people here, that's fine. So since 2006, the Ghana postgraduate training program has been funded entirely by the Ministry of Health. And as we've added more programs, the Ministry of Health has funded GYN-ONC fellows and UroGyn fellows and pediatric ophthalmologists. And I think, Jody, they funded midwives from the very beginning. So we've had incredible support from the Ghanaian government. This is a picture. So the Gandhi Memorial Hospital is the largest hospital in Addis. They do about 25,000 deliveries a year at the Gandhi Hospital. And this was a clinic that was started there. And you can see same old maize and blue corny things, right? This is the Gandhi Memorial Hospital Mishu Clinic. This was a family planning reproductive health clinic. And Mishu, believe it or not, means compassion in Aramaic. So they said, what are we going to call this? And Sanait, God love her because she's just as corny as I am, said, we're going to call them the Mishu Clinic, and we're going to have a sign on top of, and if you go around Ethiopia now to every single medical school, if you go to Gemma, wherever you go, there's a Mishu Clinic with a maize and blue sign over it in Aramaic and in English talking about the care they give.
Who's that tall guy?
Huh?
Who's that tall guy?
I don't know who that tall guy is. But that was the woman who was the director of that clinic. This is a picture of the transplant center at St. Paul Millennial Medical Center. And this is one of my favorite pictures. You saw there that they started a whole bunch of things. One of the things they wanted was a transplant clinic. And so Jeff Punch, who's one of the transplant surgeons here, said, I'm interested in helping with that. And so he went over and he took some of the nephrologists and they started a transplant program. They converted an old hospital into the transplant center for Ethiopia. The first transplants in Ethiopia were done at this center by Jeff Punch, who's the second person on the left there, and by the guy who's now the chief of surgery at the St. Paul Millennial Medical Center, who worked with him as a resident to do these transplants. They started doing batches of transplants. They first did 10 over a long weekend, then they did 10, and then they did 40, and then they did 40. But the reason I like this picture is because the person in the middle, the short young man with the, I guess, green, well, maybe that's probably a Michigan blue baseball hat. Let's go ahead and say the kid in the blue hat was the first person to receive a kidney transplant. He was moribund. He was within weeks of dying. He got a transplant from he got a living donor transplant from someone in his family. Okay, this picture was taken 5 years later, and the person on the left is his pregnant wife. So this is a person who would have been dead, and now here he is having a father. And so that picture was taken in front of the transplant center. So during this period of time, the maternal mortality has come down steadily. And so the good story is that not just in Ghana, but around the world, the Safe Motherhood Initiative has played an important number. But women are still neglected. I'm going to kind of almost finish with this picture. This is a picture of the New York Times, I think from 2014. Ebola was rampant in West Africa, and it was a particular problem in Guinea, Sierra Leone, in several countries. Anyway, so there was a successful campaign against Ebola. Hundreds of millions of dollars were invested in treating Ebola locally, finding a cure for it, so on and so forth. And this is a picture of Salome, who was a nurse who lived on a compound with her parents. Her father was a doctor, her mother was a doctor, she was a nurse, her sister was a nurse. Her parents both died of Ebola, and her sister died of Ebola. And she got Ebola, and she was treated in an intensive care unit on a ventilator with anti-serum that was shipped in from the United States at the cost of hundreds of thousands of dollars, and survived. And then went on to take care of Ebola patients because she was immune now that she was survived from the disease. Interestingly enough, 2 years later, she presented to her parents' compound seizing in labor. And she had, remember I talked to you about preeclampsia, that strange disease that people get? So she got pregnant 2 years later, got to the compound, there was no hydralazine, there was no magnesium sulfate, there were no drugs to treat her seizures, and she died. So this is the burden that continues in these countries, where we invest in interventions against infections because we're worried the infection is going to come to the United States, but we don't leave any capacity to take care of things like pregnancy. And that's what's missing from the kind of global perspective, and that is the importance of primary care and health systems that provide primary care. So there's good news and there's bad news. So I have to end with one more Michigan quote. I mean, I think there are lots of good things to tell about the Michigan story in Ghana. I think one of them is about sustainability and the engagement that we have, the breadth and balance of that engagement. And Bo Schembechler said, those who stay will be champions. And I think this is an example of a program that's now been going on for over 30 years, and a program that can be successful and can have an impact on learning, on education, on women, and actually save women's lives. And I'm going to stop right there and be happy to answer questions. Great.
We're going to have a little discussion, then open it to the audience. I thought that was wonderful. Thank you so much. I really loved what you said about global experience not having to mean necessarily an international experience. And when you put that map up of, this is sort of just an historical observation, when you put the map up of Ghana and, and talked about the downstream effects of this program, what just came into my mind is this is something that two of the early presidents of the university actually talked about.
James Angel a lot.
James Angel a lot, Henry Philip Tappan, that this was one of the functions of a university, was to generate these downstream effects, and that it was in fact part of the democratizing function that universities are supposed to perform. And I just thought that was just a resonance that hit me when you had
I think that's right. I mean, I think there's so many lessons that we learn with educations at public institutions that work for the public good, right? One of the interesting things in Ghana is, well, two things. Mary Sue and I, when she traveled around the country, we visited Kumasi, and she had an appointment to meet with the president of Kumasi, the University of Science and Technology. And we walked in the room, and she was introduced by the protocol officer who said, Mr. President, this is Mary Sue Coleman, the president of the Michigan State University. And Mary Sue looked at me, and I looked at her, and we had those moments of, should I say something? And we both decided not to say anything in milliseconds. And this guy, who was the president of the Kwame Nkrumah University of Science and Technology in Kumasi, which is in the middle of the country, said, no, she's the president of the University of Michigan. That's different than Michigan State University. It turns out he had his PhD from MSU. And he went all through maize and blue, yellow and green, this, that, and the other. But, I think a lot of, and so at the same meeting, or in another meeting with one of the university presidents, we were talking about the university, and Mary Sue said something about, one of the strengths of the University of Michigan is we own our own hospital. And this president said, what do you mean you own your own hospital? And she said, we own our own hospital. We're a public university, and we own our own hospital. And you could see the wheel starting to turn. And he said, how is that special that you're a public university? And this was the president of the University of Ghana, who had never realized that Harvard and Yale and Hopkins and Emory were not public universities, because all the universities in Ghana at the time were public universities. That's the only model they had. And so that kind of, number one, recognizing that there are different models of how public institutions function. And in fact, at the end of the meeting, he's like, you're a lot more like us than those other universities, and now I understand why, because you're a public university. I never realized there were public universities. He never realized there were private universities, is what he never did. The University of Ghana now has its own hospital. That guy, as soon as she left, said, build me a hospital. And now the University Hospital at the University of Ghana is being fought over by who owns it. Is it the Ministry of Health or the Ministry of Education? But it works to the benefit of the university. And certainly University Hospital here has been an amazing resource over the last hundreds plus years for the university. So, right. Yeah, I mean, there are just so many lessons about the public good, as it were. And I think I think there are lots, we've had lots of presidents that have talked about the importance of public good working on public goods, right?
Yes, right.
So it's not just the football coach.
It's not just the football. No, that's right. That's right. So maybe we could talk a little more about the impact of this work that you've done and the program on U of M. It's the pin partly, right? But it's not. And by the way, yeah, those are popular in all the iterations that they have been developed with all these other kinds of collaborations. We even did it with the Royal Shakespeare Company. We had the Block M and the little RSC flag, and they loved it. But beyond that, you showed how many medical departments or health departments have become involved. But this also was part of a big impact on the university more broadly, right? I think that Mary Sue's decision to get engaged internationally was a real turning point for U of M in a lot of ways. And so much, I mean, you were involved in that planning and so forth, and so much of the ethos that you established as part of this program, I think became the ethos of U of M to do with global engagement, or at least that's the aspiration with a lot of the global engagement. The African Studies Center would not have happened were it not for that trip. The University of Michigan, the African Presidential Scholars Program.
The UMAPS program is
the UMAPS
really...
program, exactly. And I want to mention just a few other people. I mean, Lester Montz, Kelly Askew, who I think is actually on YouTube watching, Mark Tesler, Ray Silverman. These are all people that had a lot to do with this.
Right.
But this is in a lot of ways, I mean, these are in some ways the children of your program.
Well,
too.
but these are all my friends, because we were all plotting to do this together, right? I mean,
Yep.
Lester plotted to bring the Michigan Gospel Choir over with Mary Sue when she was on a trip. So there was a lot of tactical thinking or with strategic goals that people had. I mean, my friend Ray Silverman's been working in Ghana building museums and demonstrating what museums can look like when you build them from the ground up over there, and then bringing that information here and bringing students both ways for decades. And you know, both the International Institute has certainly been involved with this as well. But I think lots of people holding the university accountable for doing this in an ethical way and not just going after the money, not just going after the grants, but doing this for the right reason. Why are we sending our students over there? What are our, what do we want them to learn? What are the values that we want them to learn? And how do we want to make them into global citizens? I mean, people have mentioned kind of global democracies and democratization. And I mean, I do think that the universities can play a role in global democratization. I believe in that, corny as it sounds.
So you decided to stick with Ghana.
Yeah.
And you had some personal reasons for doing that, but it seems like also, you know, I mean, you talk a lot about the importance of the local community in these collaborations and understanding the culture and so forth, and those things just take time, right? Those take time. So I mean, is this just the way to do it, so to speak?
Well, you know, first of all, let me just say that I learned a lot about community-based participatory engagement from Barbara Israel in the School of Public Health. I mean, I didn't, you know, this didn't come de novo to my brain. But I do think that building trust is really important. I mean, I came from a private university, well-known large private university in Baltimore that will remain nameless, that had a history in the community of coming in on a regular basis and saying, we're here from Hopkins to help you, and then abandoning those projects. And so I was very sensitive to that, you know, we're here from whomever, the US government to help you. And then at the end of 5 years leaving and just pulling the rug out from people. And so from the very beginning, for me, developing something that was sustainable was extraordinarily important. And if I didn't feel that Michigan was gonna continue this, I was loath to do that. And I think a lot of us here, Joe Kolars and others, are very, very tuned in to making sure that once we start something in a big way, once we develop a platform with a major effort across multiple units and multiple schools, that we really try to build something that is going to be able to have legs. I mean, one of the other things that I tell people is that there are two great institutions in Western civilization: the church and the universities. I mean, once you start a university, it doesn't go away, right? I mean, it digs deeper and it expands and it gets bigger and bigger and bigger. And that's certainly what we've seen happen in Ghana. We started with 2 medical schools. There are now 7 medical schools in Ghana. And they're thriving. I mean, they're full. They're supported by the government. And, you know, after there were 5 public medical schools, people started, you know, private medical schools. And a lot of people are, you know, sending their kids to the United States for college, and then they're coming back to do their medical schools in Ghana. And more we're seeing African Americans who go to college in the United States and are coming to Ghana to go to medical school. So there are interesting opportunities in terms of exchanges for people to do medical education, to do graduate medical education. And I know at the Family Health Medical School, at least 5 people in the first class of 30 were Ghanaians who'd come to the United States and gone to Colgate and other places like that, and then gone back to go to medical school. And the private medical schools in Ghana are like expensive by Ghanaian. They're like $8,000 a year for tuition, which is like, psh, right? Gee, sorry, with tuition, your annual cost is going to be $15,000, which is nothing compared to what 1 year's tuition is going to cost in the United States. So, I mean, they're a good deal, and they're world-class educations because they're using the same textbooks and the same activities. And so they're huge opportunities. And we've seen the same thing, you know, it's been really important that, you know, the School of Medicine was doing something, but also the School of Nursing was doing something, because we could partner our students together. And then LSNA got involved. Kathleen Sienko in the School of Engineering has got an amazing global health design program. And she takes engineering students and nursing students and LSNA students and medical students. And those interdisciplinary teams are the model for interprofessional training and education, and how rich an experience it is for those freshmen in sophomores or juniors in LSNA to be on the same trip with graduate students, and for those graduate students to teach the undergraduate students. Yeah. So there are innumerable opportunities, I think, that are involved with this.
Well, a lot of this comes from this, I mean, this idea from the very beginning about equity within the relationship, that this was a full partnership with the Ghanaians. It was not, as we often heard from other potential international partners, like you just said, are you going to be another university that swoops in? You'll get all these publications, our people aren't anywhere to be seen on the publications, and then you leave.
Right. No, we've been very attentive to that. And you know, I learned things from Ghana that I used other places. I was the editor of the International Journal of OBGYN for a number of years. And we set up a policy when I was the editor that we would not accept for publication articles from low and middle income countries unless there was a co-author from that country. And we were the first, you know, 5 years later, The Lancet did the same thing. But, you know, you learn things and you start the trend and you start saying, well, you know, how is this going to work? Because, yeah, the Ghanaians were afraid to have people come in and steal their data and then write a paper and, you know, it's written by a bunch of people from Norway or whatever. And in fact, the Ghanaians want to get promoted too, right? They want publications. They want recognition. They need a CV to be able to get promoted. So it's about equity.
Right, and it's building a professional culture. Yeah. So you mentioned the importance of the political stability in Ghana, which was not a foregone conclusion when you first went there. I mean, it was still an authoritarian regime under Jerry Rawlings.
He knows that I was arrested and thrown into.
Well, I was going to say, I can't let this go without you telling the story about your trip to Osu Castle.
Yeah, so, I mean, the first time I went to Ghana, I went under the auspices of USAID, and I was, one of the Ghanaian doctors was taking me on a tour, and we were chatting and not paying attention. All of a sudden, we were surrounded by people with machine guns, and we moved too close to the president's palace, which is an old slave castle. And they took us out of the car, and they took us into the slave castle. And I was sure I would never be, I mean, nobody knew where we were. And I was sure we would never be seen again, because once you get in the castle, there were like tanks and machine guns to protect I mean, it was a dictatorial military government at the time. So I was like, they're going to kill us and we'll be dead. And I said in the book, I think if we'd had cameras, we probably would have disappeared. But we weren't taking pictures. I didn't have a camera. He didn't have a camera. We walked out. His car had been totally dismantled. I mean, you could see the networks of his car. And after a couple hours inside, I mean, we were taken literally inside the president. It's like being taken inside the White House, right? And you're thinking, God, if they take me inside this building, they're never going to let me out. But, you know, I got out and I decided that I wanted to go back again. And, you know, Rawlings went on to become, you know, to have a military government and then a civilian government, and then gave up the presidency. So, you know, he came around to kind of the Western way of thinking.
Well, you say in writing about that you were actually, I think you said you were surprised by how much equanimity
Yeah.
you had under these
And I'm surprised I didn't freak out. But I was totally calm. I was like, okay, I'm going to die as, I'm in the basement. Nobody's ever going to find me. They're going to throw me in the ocean. And,
Well, I think it's great and brave of you to go.
but I think also I'm an obstetrician, so I'm used to dealing with really bad stuff. So,
So I have one more question, and then we'll open it to the audience. One of the really interesting things about the book, we were talking about this a little bit ahead of time, is how you weave interviews with these different people who were involved in one way or another into this. And I thought it was great. I mean, you hear things in these people's own voices. It really sort of gives emphasis to the idea that this was partnership, this was collaboration, this was more than one person doing this. And I wonder, I mean, just if you could say, how did you come to that? How did you decide on that?
yeah, so, I've been doing this for 30 years. And as I was writing the book, after I'd told my kind of personal story, I wanted to talk about the progression of the program and other kinds of things. And I thought, I just can't have this entire book be about this is, Tim Johnson did this, Tim Johnson did this. These people, understood the gospel according to Tim Johnson. And so I thought maybe the way I can, and then I thought, well, maybe I'll have other people write chapters. And then I thought, well, this is really a personal story. And so I thought, well, what if I interviewed people and took their stories? So Emma Lawrence, there's a chapter on medical education. And I interviewed Emma Lawrence when she was a chief resident. She has now gone on as a faculty member at the university. But I talked about how she went from being an undergraduate student in North Carolina to being a medical student here to being an OB/GYN resident here and to weaving working in Ghana into her program. She now has a 5-year grant from the Fogarty Foundation. She spends 6 months out of the year in Ghana. She's a real Ghanophile. And she had started as an undergraduate at UNC working to support an orphanage in North Carolina. So I thought, okay, let's let Emma talk about what her experience is so other people can experience it. And then Richard Adanu was a faculty member at the University of Ghana, who's now the rector of the Ghana College. I interviewed him about faculty development and what did it mean to train faculty in Ghana to go on to take academic careers. And then Kathleen Sienko had this interesting program from outside of the department where she really developed global design in the engineering school and is an Arthur Thurnow professor and does all kinds of really interesting things and has developed a whole career around kind of engineering, implementation of engineering into third world countries. And so I thought, okay, let's have that perspective. I could have interviewed Ray Silverman, but Kathleen seemed to be the person, partly because she did work in Africa. And then finally, I wanted another outside perspective. And so when we started the work in Ethiopia, Leah Tedesse had been the chairman of OB/GYN. And then she became provost of the university, and she was very involved with Senite and getting the program organized. And then she moved to the United States and was the director of the Center for International Reproductive Health Training here. So I interviewed her when she was the director of the Center for International Reproductive Health Training and talked about what it had been like to marshal this program in Ethiopia. And I think having those other perspectives and kind of leading people to talk about how they kind of experienced this ethos that was kind of part of the program all the way through became important. Now, Leah Tedesse then went back to Ethiopia, joined the Ministry of Health, and she's currently the Minister of Health of Ethiopia. I mean, when we started working with Dr. Tedros on this program, he was the Deputy Chief of Staff, the Deputy Minister of Health of Ethiopia. He's now the Director General of the WHO. So, I mean, I've been able to work with kind of amazing people. Some of the people in this room that I've worked with are pretty amazing people. So, I mean, quality counts too, right? I mean, doing this at the University of Michigan with the kind of collaborators that we have. And with Mary Sue Coleman, who said, we're going to have a MAPS program, and with Cheryl Moyer saying, let's start working in Lergu, and with Jody Laurie, who's got an amazing program in the nursing school, and with Joe. I mean, it's really been a team effort. Right. But I think all of us have shared this idea from the very beginning. I mean, we've grown up with, we all started this 25, 30 years ago. And I think we've all grown up in a sandbox where Michigan values, these values of a great public institution and institutions working for the public good and shared decision-making, all were part of the fabric of the way we grew up and the way we behave now.
Yeah, yeah. So on that note, I think it's a good time to open to questions from the audience or from online. If you could wait for the microphone, we're trying to capture all of this, so thank you.
This is Cheryl Moyer. Thank you so much, Tim. This is so great to hear about. And I think you began to answer my question with your last comment. One of the things I've always admired about you is your ability to take anyone with a pulse and get them excited about going to Ghana. And the next thing you know, you're on a plane, and you didn't know how this happened, but Tim told me I needed to go to Ghana, so the next thing you know, I'm in Ghana. And
either their parents or their husbands were in my
Right.
office saying, "What the hell have you done to my child or my husband?"
But I think one of the questions, you had talked about how hard it is and how important it is to develop trust. So the partners in Ghana have a deep trust for you and for the program.
They have a deep trust for the University of Michigan,
And I think
because
that
the University of Michigan has not let them down.
And I think that was my question for you is you were so generous with your contacts and just saying, you need to talk to this person, you need to talk to this person, you need to talk to this person. And you never seemed to pause to wonder if any of us were going to mess it up. And I would just love to hear your thoughts on your openness with all of your contacts and your just blind
I
trust
did worry
in the
about
rest
people
of
who would
us.
mess it up, and not everybody got those, got widely connected, right? I mean, first of all, the quality of the people we have at this university is outstanding. So, I mean, you're already dealing with people that are smart. But you have to have people that you can trust and people that share values. And so, people the first time in my office are treated generously. But it takes a little bit for me to give you a whole network of my colleagues in Ghana, because I don't want people to mess that up. And I think all of us behave that way. It's not that we're trying to keep people, I mean, here's my friend, here's a person that you can talk to is an easy thing to get. But to start building a network of work, I think is something that we need to be very careful of. And there have been a couple of experiences that haven't been exactly wonderful. So, I mean, once you're good friends with people, I mean, everybody realizes that not everything works out. And not every date is perfect, right? And so, I mean, I think it's this building trust and consistency and knowing that you're going to be back, and if this doesn't work, then we'll revisit it. And if somebody is a particularly difficult person to deal with, or if somebody muddies the waters, that you're going to find a place where they're going to be successful. I mean, that's one of the biggest challenges that we all have as leaders, and that is identifying people's strengths and identifying their weaknesses, and making sure that we're playing to their strengths and protecting them from their weaknesses, right? And I mean, those of us who've been department chairs and leaders and deans know that we all have weaknesses. I mean, I know some of my weaknesses, and I try to play to my strengths. I mean, I have financial weaknesses. I'm terrible with numbers. So I always had a very strong MBA as my right-hand person in the department, because I don't care about numbers, right? I mean, I know how important they are, so I want somebody really good taking care of that. But I'm the ideas guy. I'm the vision guy. And I always need to make sure that I have a good numbers person with me. So you need to know what your strengths, you need to know individually what your strengths and weaknesses are. But even more importantly, you need to be able to assess the strengths and weaknesses of the people around you. And it's a bit of a challenge when you're dealing with freshmen and sophomore and juniors compared to graduate students, right? But it's been surprising to me how well we've done with some of our very, very young learners. The book's going to help, because I'm going to say, here, read this before you go.
I think we have an online question, and then Andrew.
Olti says there are college students interested in doing global health work in Albania, where rural medicine is a necessity and many doctors are leaving. What advice do you have for starting that sort of work?
Well, one of the points that I make in the book is that there are lots of different ways of doing global work. I mean, you can go on a service trip, or you can do an NGO. I actually believe that the best way that I know how to do global engagement is through academic institutions. I mean, I think universities, public universities especially, are a particularly good way of engaging in and developing long-term sustainable partnerships. Because you're training people to do capacity, you're training them to do research, you're training them to do leadership, all the things that we do in an academic institution. So I encourage people to look to academic institutions, teaching hospitals, public schools, secondary schools of high quality, and partner with those so that you're building capacity at that level.
There's a hand, yeah.
Jody Laurie, School of Nursing. Thank you, Tim. That was incredible. So you have done amazing work for 30 years, and I'm wondering what your vision for the next 30 years is for Ghana and for global health education.
Well, my first vision is there's the next generation of leaders that's going to take over. Hopefully that are imbued with the ethical principles that we've instilled in them, but that are going to use their new tools. I mean, I think the next generation has new tools in terms of AI, in terms of interconnectivity that they're going to use, in terms of drones, in terms of all kinds of other ways of doing the work that we've done. And when we first started going to Ghana in 1987, 1988, there was a huge need for education, and we used to take huge boxes full of these things called books over. You remember that. I mean, we would, pay lots of extra money to take books over on airplanes, and now we can take 10 times as much information over in a zip drive. So we've totally transformed what's happening. I'm really excited. So my book is coming out from University of Michigan Press, and the book is open access. And as of today, students in Ghana, learners in Ghana can access it for free and download it for free. And that's what's going to happen, is that everything is going to become open. I mean, there are more, now, having said that, don't feel sad for Ghana. There are more per capita cell phones and smartphones in Ghana than in the United States, because they simply skipped over landlines. Landlines never existed in Ghana. And so, everybody's got 2 cell phones over there, and the medical students have all got 3. And they can download everything on those. They can get more information from WhatsApp and from medical apps, and they're going to be able to walk by and see patients and plug in the symptoms, and the computer's going to make the diagnosis for them. And they're going to be handheld technology, so we can have bedside ultrasound and bedside laboratories and laboratories in a box. And so the technology that's available in medicine is going to radically change. And the other thing that's happening is that populations are changing. I mean, the internet now exists in Ghana, and doctors who used to tell their patients, well, just do what I say, are being met with, well, I just read on the internet, tell me about this. And that's happening the literacy in Ghana is very, very high. So that means that everybody, and the access to computers is very high. And so people know how to do Google or Bing or whatever they're doing, and read about, why is my left leg swollen? And go into the doctors with questions, and why are you giving me this drug to take? I think that's radically changing healthcare. And it's radically going to change engineering. It's radically going to change the other kinds of disciplines as well. So what I see is hopefully generations with the same values who are able to spread this out and expand this kind of capacity to other countries where it hasn't happened before. I mean, Ghana has got, 25 million people, 32 million people now. When we started there, it was less than 10 million people. So these countries are rapidly expanding, and the maternal mortality is disproportionate to low and middle income countries, but the hugest, most of the maternal mortality occurs in a few countries. Nigeria, which is very difficult to work in. Ethiopia, which is less difficult, but still difficult to work in for political reasons. The Democratic Republic of Congo, Bangladesh, and India. I mean, Ghana was easy compared to working in those places. And so figuring out how globally partnerships are going to work in those countries, especially with the hegemony of China and with with Russia, I think, are going to be problematic. I mean, there have been real problems in Ghana already because of China. China came in and invested huge amounts of money building infrastructure in Ghana. Hospitals, medical equipment, roads, railroads, all kinds of stuff. And now, first of all, Ghana has to pay back the debt on it. And secondly, the equipment's is starting to fall apart and it's not being replaced. And so, you know, there are whole cardiology units in Ghana that were built by the Chinese that are already starting to fall apart. And so, again, we're going to have to deal with you know, global leaders that have not been functioning in a way that's going to develop sustainable work. And that's going to be a real challenge as kind of the status of the United States in the world goes down. And people are less and less, you know, willing to say the United States is always right. So yeah, no, I think so. I think, you know, technology advances, all kinds of cool stuff that I don't even understand, that my 14-year-old grandson understands. You know, the Gen Xers, you know, the millennials, I think, are going to be incredible in terms of the work they do. They're very interested in doing global work, and we as universities need to prepare them and let them loose to do it in an entrepreneurial, exciting, new way.
One more online question, I think.
Molly Stout asks, can you comment a little on the comparisons and contrasts between how women are forgotten in Ghana and in the United States in terms of medical practices?
Well, I mean, Ghana has rapidly changed in the last 30 years. I mean, when I first went over there, there was a lot of discussion about, you know, women don't count, who cares, especially in the upper half of the country where it was easy to replace women, where women were replaceable. You know, if a woman died in childbirth, a husband could get another wife or something like that. Those times have gone away, and suddenly women are being recognized because of their political power. I remember I was over there about 15 years ago, and we'd had a real problem with maternal mortality being recognized. And the wife of the Deputy Minister of Energy died in childbirth. And I remember it was headlines on the 5 o'clock news, wife of Deputy Minister of Energy dies. And the next day, the president of the country came and said, it's unacceptable for women to die in childbirth in our country. Not just the wife of the Deputy Minister of Education, but any maternal mortality is unacceptable. So to have governments and government leaders recognize the importance of women and talk about, you know, women in our country, you know, function equally to men, women should get the same education as men, you know, the status of women should be recognized on the same basis of men. So gender equality is a big piece of all this. And people are starting to see that when you know, in Ghana, more than half the women in medical school are now women. Did I say that correctly? More than half the women, more of the people in medical school are now women. And that's going to radically change the way medicine is perceived and medicine is practiced. And so I mean, you know, gender equity, gender equality is going to be an important part of all this. In Ghana, tribal equality and they're tribal issues. And so there's lots of discrimination that happens, not racial discrimination, but tribal discrimination and income discrimination. So, I mean, the causes of maternal mortality are ubiquitous. The causes of inequalities and disparities are ubiquitous. These are common problems that we need to work on, and there are lessons for us to learn from the work that's being done in Ghana, and lessons for Ghanaians to learn from the work that's being done here in the United States. Thank you, Molly.
So I just have one comment that I wanted to make sure others heard. Tim, your work in Ghana has been so remarkable and so lasting. I have a colleague in Ghana who explained to me that when you are in Ghana, people want to know who your father is. Because once someone knows who your father is, they can kind of put you in context. And so everybody can relax because they have a sense of where you're from. And he said, for all those of you at Michigan with your big block M, when you're in Ghana, Tim Johnson is your father.
Well, I mean, I think one of the important roles of those of us who work at universities is to offer opportunities to our students, right? And so, I mean, you know, I take that as a compliment, but what's really important for me is to recognize that part of my role as an academic institution leader is to make those opportunities available to my students. And you make that available to my students by role modeling yourself and by building trust and by building sustainable programs and by building equity. But it's mostly around trust. And I mean, I think that's right. I mean, if you go from the University of Michigan to Ghana and say, I'm here from Michigan, people will say, hello, come on in, you know, because they've had experience with 30 years worth of students and learners and faculty and visitors and stuff like that. There are lots of other institutions that are very well known, that are very prestigious, that are private universities, and they say, I'm here from X. And not just from the United States, you know, I'm here from Oxford, I'm here from Nijmegen, I'm here to help you. And they're treated very, very differently. They're siloed and they're watched before they're trusted. And I think I mean, one of our jobs at the University of Michigan is to build value for the University of Michigan, right? That's equity for the University of Michigan, right, Peter? I mean, one of our jobs as faculty is to build equity and to make people's degrees worth more and to make it easier for students to have the kinds of experiences that we want our students to have. So, I mean, I see that as my responsibility as a tenured professor.
Well, Tim, thank you so much for this discussion.
It's been a
This is
pleasure. Thanks a lot
fantastic.
for having me.
And thank you to the audience. Our next session of Making Michigan will be November 9th and is titled A Stunning Achievement, the Improbable Collaboration of U of M's Bentley Library and the Vatican Archives. Our speaker is going to be Fran Bluen, the former director of the Bentley. So if you join us, you'll hear some remarkable things. I've heard a version of this talk about one of the world's oldest and most amazing archives and some fascinating U of M connections. Thanks to Andrew Rutledge for monitoring YouTube and the Michigan media team. We are open upstairs in the observatory until 9 o'clock. There are docents who can show you around. So if you want to see where U of M started as a research university leading to everything we now have, just go upstairs and take a look. That's for those of you here. I hope those of you on YouTube can join us sometime. And until we all see each other, be safe, stay well, and keep hope. Thank you.